Hello and welcome to this tutorial on the use of 2.5% polyacrylamide. Today I'm joined by Dr. Jason Lowe and Dr. Leigh Clifford from New Zealand, and they'll be taking us through their experience of this product. They were instrumental in the development of the product and how it is used in the Southern Hemisphere. So I'll pass it over to Jason and to Leigh to take us through this presentation. Thank you very much for giving up your time today, gents.
Yeah, that's all right. Thanks. We're on home detention over here in New Zealand, so it's a good time to be doing this sort of stuff. So thank you very much, Greg. Yeah, so Leigh de Clifford, my colleague here, Leigh will talk through most of this presentation. He's just presented this in Denver, Colorado at the AAEP, but we'll also talk a little bit around some of our personal experiences with the product. Both being in practice and using it in our own cases. Slide, there we go. So yeah, the study that Leigh presented recently was a study that him and I oversaw. It was conducted in Melbourne, Australia. It was a single site, double-blinded prospective study, and we compared the efficacy of 2.5% polyacrylamide against two other positive control products, triamcinolone and hyaluronic acid, just in the intercarpal joint of racing thoroughbred horses. So quite a select group of horses and obviously quite extreme workloads. And I guess the outcomes from the talk really, what we'll go through the study today and just show you that the 2.5% PAAG was superior to those other two treatments and longer lasting. It's also really interesting that it did take 4 weeks to show that superiority. There was no difference between treatment groups at 2 weeks, but far greater superiority in the 2.5% PAAG treated groups at 4 and at 6 weeks. There were no reactions in any of the treated groups, so it's very safe. And this was a group of horses with mild naturally occurring OA. So quite different to the published literature or most of the published literature on 2.5% PAAG, which has been used more in the chronic sort of end-stage OA cases with significant radiographic changes, whereas ours was very much sort of more mild and naturally occurring arthritis. I guess a bit of background, Leigh, do you want to talk to yourself there and introduce yourself?
Oh, yeah, g'day. So I'm actually Australian, living over in New Zealand these days.
So that's a family photo in the centre?
Yeah, it is. Yeah, I'm the good-looking one in the middle, and yeah. So basically, where I'm from, there's a lot of cropping, a lot of superfine, ultrafine merinos, a fair bit of rodeo work, and we actually we do race thoroughbreds in Australia on dirt, but it's a slightly different kind of dirt. There's no real work goes into it. That's in the outback in Birdsville. It's in the centre of Australia, and then down the bottom is the southwestern corner of Queensland, where they race camels when they get desperate. So yeah, that's. I went to university in New Zealand and then went back, practiced in Australia for a few years, then followed by the UK, and then yeah, now in New Zealand permanently these days. And Jason will tell you a bit about himself in the next one.
Yeah, well, we both in practice, well, I'm out of clinical practice now. I was an Equine vet for over 20 years, worked at Rossdale's, worked up in Oakham in Leicestershire in the UK, then moved back to New Zealand. The practice Leigh's in now, that's where we met. He was, it's very close to Hobbiton, where they filmed the Hobbit movies. And of course, New Zealand's probably best known for the rugby, but we shouldn't talk about the rugby with the recent World Cup loss to England. So we'll move straight through.
No, you can talk about it if you want.
No, that's fine. Moving on. So I guess, yeah, 2.5% PAAG in New Zealand, it is Arthramid is the brand name, and that's registered, but obviously worldwide in other country jurisdictions, we're talking about 2.5% PAAG. Comes in a pre-filled 1 ml syringe with a Lowe catheter on it, and that's really important, the Lowe syringe, because it's quite viscous and difficult to inject into the joint.
Jason, just to confirm there that you're saying it's registered. New Zealand, it is a licensed veterinary medicinal product, correct?
Yes, correct.
Yep.
Pending in Australia. We're just going through the paperwork side of that, but the ACVM have approved it. We're just waiting for that final certificate to come through. So I guess, yeah, what's interesting about PAAG, and I know Leigh's got, I think there's some stuff in the next slide too around Naren's work on this, but the unique thing about the 2.5% PAAG is this cross-linking technology. It's what makes the 2.5% PAAG quite unique in the world. It's the most stable hydrogel available. And it integrates fully into the tissue, and we believe that's happening because of the pore size that's created by the 2.5% concentration of the active, which just allows that cell migration and tissue integration without some of the adverse reactions that that have been noticed with other hydrogels.
And I suppose one of the big things about the product is it is hydrophilic. And as a result, it does interchange water molecules readily with the surrounding tissue. And we do know that as a result of this inline cross-linking technology, that as you said, it's stable and it's an irreversible backbone that extensive stability data has shown that it doesn't alter, whether it be in a syringe or in a mammal, whether it be rabbit, pig, or horse, and that's both been shown in arthritic affected and also normal synovial joints, as well as several soft tissue components. And I suppose the other thing too is that this product, the equivalent product, is actually registered in over 40 countries worldwide for human usage in soft tissue reconstruction. And its primary use is two avenues. It's urethral bulking in women with stress incontinence, but also facial reconstruction of soft tissue. And in particular, it's in AIDS patients that lose the fill in the face. So they're using this product because, unlike other fillers, it allows integration of the body through the product. It doesn't create a walled off structure. And so we know that from the extensive work, primarily done by Leigh Christensen, which we'll touch on a bit later, that the body grows through it, never walls it off, and as a result, it's far more stable. It doesn't migrate, and it's as we'll discuss later on as well, that it is the superior hydrogel available on the market.
Yeah, I think that's pretty cool.
I think you touched on a really important point, is the infill of the cells into this product. I've always found it fascinating that the porosity here, and we always touch on porosity, but I don't think we look at it seriously enough on the right porosity for the right cell growth. I mean, this is an ideal porosity for fibroblastic growth, and it's been demonstrated, Leigh, as you've already said, with the use of it in human urethral bulking, whether it be in facial filler, etc. It's all fibroblastic growth, isn't it? And when we get to synovial tissue, we'll be talking about fibroblasts. And in my experience, when we look at cell growth and scaffolds, we've always struggled in the past to understand what porosity is ideal for whatever cell. I mean, go back to days we used to use it for bone grafts or synthetic bone grafts, trying to get the right porosity to encourage, osteoblasts to grow into, etc. And we always found that what would make a scaffold a success is getting that porosity. And I think, however that company designed the scaffold, the cross-link, etc., the stability of it, it has demonstrated that it is the ideal porosity to allow these cells to infiltrate it and use it as a scaffold.
Yeah, I completely agree, Greg. It's a great point. And I was actually biking recently with a human plastic surgeon, and he'd done his PhD on, PhD on tissue scaffolding. And so we had a great conversation around that. And like you say, it's a really interesting thing about the product. So on to the next slide, I guess, it's really just that it's that biocompatibility, which, as Leigh said, has been well published now. It's homogeneous and non-particulate, and I think that, it's that cross-linking, and again, it's understanding that it's a polyacrylamide. It's the polyacrylamide molecule that's infinite in length, and this was some of the work we did with the regulators around the chemistry and manufacturing of the product, and trying to get away from, or understanding that it's a polyacrylamide. And I guess, again, to bring up the elephant in the room that seems to sit around this product, around acrylamides and their various toxicities and stuff, but this is a different product, and not obviously related, but I think it's very important when we look at the safety of this product to understand that.
Yeah, definitely. I think it's one of those misconstrued points. But as you can see, as you were highlighting, Jason, you look at this scan electron microscopy image, which is taken at 7,500 times magnification. It was produced on behalf of us for our research and the safety data by Otago University in New Zealand. And as you can see there, you've got the branch chain polymers, which are then linked with this cross-linking technology. And just as you pointed out, Greg, before, it's a scaffold. That's the best way to describe it, but it's a biological, it has the ability to allow biological incorporation through this scaffolding process.
That's a really cool image, that. So we can probably skip through this because, as we know, it integrates into the soft tissue. As you said, it's collagen, fibroblasts moving through it. But let's get into
Christensen did show, as you said in that bottom paragraph there, that it primarily gets incorporated into the subintima, but also a little bit intima as well of the synovium. And that's very important when we come through to the mechanism of action. And then the collagen deposition is its primary, it's a primary mechanism of action.
Do you want to talk us through this slide, Leigh? Because I just think this is really exciting stuff. It's back to histology days.
Yeah. So this is quite good. This is, we collected this data from the safety research that we've done. And this is from I believe it was a 6-year-old thoroughbred mare that had 2 mils of the 2.5% polyacrylamide product injected to the fourth fetlock joint approximately 6 weeks before this. And you can see, for those of you out there that know what a synovium should look like under the microscope, which I'll admit it's not me per se, you've got the synovium increase in both number and size. And you can see that in general there is a blue haze in the subintima indicated by the arrow. The next slide has a high image that will show that a bit better. Yeah, and right there, we can see we've got, normally the synovium is only 2 to 3 cells deep, and you can see there you've got up to 7 or 8, and they are quite large. And so this again comes back down to the mode of action, which we'll touch on very shortly. But that's where the product integrates. Unlike initial concepts on how it works, it isn't free floating within the joint. We know from the work previously done, again, mostly by Christensen, that it gets incorporated into the synovium, and that process starts at around about 7 days. And it can go as much as 10. It's important, and we'll touch on the reasons for why that's important later on. But so about 7 to 10 days, it starts being incorporated into the synovium, and we don't get full integration until roughly that 4-week mark, because that's how long it takes for this collagen deposition to occur.
So we refer to that, we always said it's adsorbed, not absorbed. So we get the tissue growing into it, how it's incorporated. Rather than diffusing into the tissues, it's the tissues that kind of grow through it and then become incorporated. Would that be right?
Yep. And then you get this new layer of synoviocytes on top of, because they've had to go through the product and then they're laying down on top of the product. So that's the perfect description. Yeah,
that adsorption is obviously a demonstration of it being used as a scaffold.
Very much, and it's so exciting that you get that new and hypercellular synovial lining, and obviously we've talked before about the need now for looking at some of that quality of the synovial fluid post-treatment, because it would only make sense that it improves. I think that's what we see clinically with a reduction in synovitis, and obviously the animal becoming less lame and then ultimately non-lame. But yeah, it'd be lovely to be able to sort of analyse that fluid. Obviously we're pretty limited in that in the equine space beyond really viscosity, but maybe that would be enough. Certainly we've attempted with some cytokine research, and I know colleagues in Germany, Mark Kuhner has as well, but we've all struggled with really that biomarker, isn't it, that shows us synovial health. It would just make sense to me that,
yeah, and certainly the work done. Yeah, the work done over in Germany, they were looking at 37 separate biomarkers, and they're struggling to find consistent results purely because of the quantitative nature of those testing panels. You know, it's well documented in all spheres, whether it be human or veterinary, of the difficulty in assessing biomarkers. So I think a lot of the research ultimately does come back to functionality.
the slide, because that's what you were saying as well, Greg, about this that tissue integration and just the cells and then collagen fibers growing through it. So that's the electron microscope work we did, and again just the showing that lovely integration through the scaffold.
Yep. So the red arrow there, everyone, is the polyacrylamide, and then the blue is the collagen fibers being laid down in amongst it. And this image was taken from the same animal that the histology samples were from previously.
So I like that theory of adsorption. Did you want to quickly summarise the Nairns and Smith's paper, Leigh? Because this is quite interesting, isn't it? We mentioned it before.
Yeah, so this is, I think that the take-home message from this paper, and probably from this discussion here, is that not all hydrogels are the same. You know, it's the same as not all cars are the same. You know, there's good ones and bad ones, and unfortunately you can get tarred with the same brush. But I was fortunate that Nairns and Smith did conduct this study on the 11 available polyacrylamides in the world, and their research found that the product that we're using, both for all the research that's been conducted and in clinical practice, is the most stable of them all. It allowed vessel ingrowth and did not become encapsulated. It had the most compatible pH range, and it was also the most consistent in terms of all the parameters that were required for pharmaceutical registration and usage. So that's a very key thing to take home. It is different to the other ones available. And again, modes of action are also different too, as we discussed, 2.5% versus 4%. There's also, some of them have additives in them. Some of them don't have cross-linking technology. So there are a lot of differences, and I liken it to comparing, for example, a cephalosporin antibiotic. You've got ceftiofur and cefquinone. Yes, they're in the same group, but they act differently, and they target different modes of action subtly, and they do target different organisms. This
is a great slide too, I guess, Leigh, which time bars work really starting to look at that mode of action, isn't it? Comparing joint capsule elasticity in an osteoarthritic knee versus a non-osteoarthritic knee to begin with.
Yeah, no, this is a fantastic paper conducted by Aziz. This actually stemmed out of the original research that was performed. I think it was back in 2011, the original research was done. But as we know, it takes time to get things published. And it's interesting here that if you do look at the osteoarthritic affected joint, the true stress values, that's the point at which irreversible damage is done to a joint capsule, is a lot lower than a non-osteoarthritic affected joint. And that makes sense for all the people that have arthritis out there, and also the vets out there that are dealing with osteoarthritis on a daily basis. We know that joint range of motion and reaction deflection are very subtle clinical signs that you get initially, and I think they're often overlooked. And we do know that the synovium is a very key important component of the arthritic process, and this is showing here that we are able to, this here highlights the fact that an arthritic affected joint has less elasticity in it. And if we go to the next slide.
And that's strong in the human research as well, isn't it? Like you say, around stiffness and capsulitis, capsular stiffness. And I think even myself over the years, and I think, we've had this discussion many times in the bar at a conference or something, and I don't know, Greg, you might have some comments as well, but I think as you get more experienced in clinical practice, you learn to trust your hands and trust your clinical judgment when you flex a horse. And I don't mean sort of the textbook flexion test. That's obviously got its place, but just actually picking the leg up and stretching it and giving it a flex and seeing where the animal reacts and says ow. comparing left and right, it's quite handy that you know, horses have left and right side, so you can always compare one joint to the other. I mean, that said, we deal with a lot of bilateral forelimb lameness, especially in Australia, on the hard racing grounds there. But just such an easy clinical test to do.
Yeah, Jason, the point that I would like to make is when I'm looking at the work that I'm doing both in equine, small animal, and outside in human management of osteoarthritis, is when we look at human and small animal, we use goniometry quite a lot. And we get to do that in small animal patients and in human. And it is a common symptom where even without much other symptoms, we start to get reduction in joint flexion. And we record that to obviously look at how advanced the disease is, because we know that that change to the capsule is part of the disease process and should also be part of the treatment strategy.
Yeah, it's a really good point. A really good point. Okay, Leigh, do you want to quickly summarise this slide?
Yeah, so what we've got here, we've got a different, two different groups compared to the previous slide. We've got in the yellow there, we've got the point at which irreversible damage is induced in a joint capsule in a joint that does not have osteoarthritis. And then what we've got in the purple there, we've got the irreversible damage induction at a higher value. And this is in a joint that was treated with the 2.5% polyacrylamide that had osteoarthritis that was clinical. So we can see that we've got an increase in the tensile strength, but also the elasticity of the joint capsule there. So what we're basically doing is what would appear to be happening is that you're strengthening up the weakest link, which is the synovium, essentially. And this, as a result, allows a joint load transfer a lot more, but also increases the ability of that joint to function at high strains and even at lower levels as well. And this is a really good summary here. And again, it shows you it allows a passive incorporation of cells, and this is synoviocytes, macrophages, and giant cells. And they have to go through the product, like Greg was saying before, in an adsorption way. And as a result, you get this new hypercellular cell lining in the synovium there. And the next slide has quite a nice...
You know, I'm just going to say there, Leigh, it comes back to some of that early discussion around the water molecules, those lightly bound water molecules that are able to exchange. And like you say, the initial work that talked about this product free floating in the joint and acting as some sort of shock absorber or something, whereas that water molecule exchange, it allows it to bond to the synovial membrane and for that integration process to start.
And so in this here, it also shows that we do get a thickened synovium as a result of both increased synovial numbers, but also synovial cell size.
I've got a thought on this process as well, and I'll throw it to the pair of you. We know that during the disease process, that the synovium, the intima, is one of those tissue gets attacked very early on. That's your acute synovitis progressing to a chronic synovitis. So we know we're getting a breakdown of that tissue, primarily because of MMP activity. So that tissue then will try to recover. This is where we start to get destruction of those tissues. So wherever there's destruction of those synovial cells, is that we're going to get infill of synovial fluid. Now, synovial fluid, as we know, hampers healing. We know that in every soft tissue structure. I have an additional thought that this gel, when it starts in its early phases, actually displaces that synovial fluid before then acting as a scaffold. And that really does help aid that sort of cell migration.
Yeah, that's an interesting thought, actually, and one we've sort of similarly considered. Because of that clinical picture, we certainly get a lot of horses that will clinically respond within sort of 5, 6, 7 days, which is prior to when we know tissue integrations occurred. So I'd agree, there's definitely something happening earlier on to give you a clinical response. So.
And I think part of that, that displacement theory that you're talking about there, Greg, I think part of that is also reducing the exposure of those already, I suppose you'd almost say, hyperesthetic synovial cells, because we know that it's a negative cycle. So if you can partially interfere with that cycle by stopping their exposure to further inflammatory biomarkers there, you're going to have a down regulation production of more of them. And so that's what I think we may be seeing in that first kind of couple of week phase, is that displacement theory, whilst the incorporation process is happening.
Yeah, and it's something in that catabolic state, isn't there? And we know that that's why it's a degenerative disease. Things get worse and worse. Whereas I'm convinced that we're breaking that cycle with this product, and that's where it's so useful, and it's used to manage these cases. And like we're saying, not waiting till we're end stage, not waiting till we've got severe radiographic changes, actually getting in there early and trying to manage these better so that they don't progress to there.
Absolutely. I think we've got to go a long way to help. I don't think vets, because I think vets will understand what the disease is all about, but owners need to appreciate that synovitis is actually early osteoarthritis. It is the driver to this disease. And once that tissue is damaged, you've got that lifelong disease.
Yeah, I agree. And I think even, potentially some vets as well. I mean, I know when I got taught at vet school, Leigh's a lot more recent graduate than I am. But yeah, it was like it was a separate disease. And yet we know so much now that it's just not. So it's part of the whole syndrome and complex.
Well, it's a chronic disease process. There are very few horses present lame that have got an acute arthritis. We were discussing off air before about the fact that lameness is the last thing that you see. That's the tipping point, and you can pick up an affected joint far before you get lameness, and that comes back down to being part of the team. On the client's team, you're looking at these horses regularly, and you'll get a loss of. You'll get a subtle loss of performance before you'll get lameness. And so it's about getting in there early, and then again monitoring these cases once you've injected them once, because it's arthritis. It's a debilitating disease that costs billions of each year in loss of performance, quality of life. It's a horrendous situation to be faced with, both in human and veterinary sectors. So if we can reduce its impact in the long term, that's only going to be good.
And I think we also underestimate how stoic the horse is, how it will cope with subtle pain, its ability to compensate, move its weight around. You've already said there, Leigh, by the time we actually see pain as lameness, this is gone on for quite some time.
Yeah, and it's interesting, isn't it? That's well sort of recognised, I guess, around dental disease. And I know Paddy Dixon used to talk about that horses won't show dental pain because obviously back into their genetics and history of out on the prairies where you're not going to be susceptible to the predator. But lameness, exactly, it must fit the same thing. You're not going to show a weakness in front of a lion chasing you down. So.
But it can come in subtle things. I had a case very recently, an advanced dressage horse, and it had a cut on the left-hand side of its mouth. It was only the left. It wouldn't resolve. They tried all sorts of different bits and issues and things like that. And then in the end, so why don't we block its front feet out, see what happens? So put a different rider on, they rode it, blocked the front feet out, different horse, not pulling on that rein, cut resolved, all because it was sore. Yeah. Wasn't lame though. We even put the objective lameness device on there. It couldn't detect it, but the head was a bit skewed, and the rider, after we blocked the feet out, said different horse. So that just highlights that what we're dealing with is it's very.
So this really is just the summary of what we've been talking about. That tissue integration has a stabilising effect on the joint capsule and synovium, increases the elasticity and tensile strength, and improves the load transfer capacity of the joint, therefore alleviating that cycle of pain and what you say, end stages into arthritis. So this was just a quick summary of some of the previous papers. Did you want us to run quickly through those, Greg? Or
yeah, no, please do. I think it'll be good for the viewers.
You want to lead that, Leigh? Because this was part of your presentation, I guess, and the reason that we focused our research onto racing thoroughbreds, because all the previous literature to date had mainly been around competition and sport horses.
Yeah, no, definitely. So there was a great body of work done in Europe on equestrian-based horses primarily. And as you can see there, only 8 of the 115 horses examined were racing thoroughbreds. So if you look back at 2012 from Jansen et al., they took 12 distal interphalangeal joints And this was again in sport horses, conducting show jumping and dressage, or performing in show jumping and dressage disciplines. And they're all diagnosed using gold standard MRI, radiology, clinical examination, etc. And Andy Bathe from Rostales and the team there presented a paper in 2016, and they took 20 distal interphalangeal and proximal interphalangeal joints, and again gold standard diagnostics, unresponsive to previous medications. Time Bar in 2015 published a really nice paper there on fetlocks, primarily with only 3 carpal joints involved. And he also in 2015 published another paper with 40 joints, and all of those were fetlocks. So if you're looking at all of those as a group, some of them were unblinded, some of them didn't have random allocation. Basically, all of them had previous intra-articular medications. There was only one paper there that did have a control group, although you could argue that the other ones that had previous treatments were acting as their own controls because they were poorly or unsatisfactorily responded to those treatments. But one big thing that we did identify, there was no standardized exercise regime. Overall, we wanted to put together a really nice paper that alleviated those issues, and also to target the racing industry, which we do know is fairly substantial, and in certainly the demographics that we work in is the bulk of the work that the clinics perform. And also the intercarpal joint is about 80% of the lameness that occurs in arthritis that occurs in flat racing thoroughbreds. Interestingly, if you look at the success rates in those papers, so Jansen et al. 2012, they found that 67% of the medicated horses were lame-free at 6 months. Time Bar et al. 2015 found that 75% at 6 months were lame-free, and this is versus 35%. And that other group of 35% was a triamcinolone sodium hyaluronate group. And so you can see there the results are quite stark. And then again, Time Bar in 2015 found that up to 24 months after a single injection of the 2.5% polyacrylamide, that 82.5% of these horses were lame-free at that time point. And Bathe et al. 2016 followed this group of horses through, not for 6 months like Jansen did, but through for 12, but also found the same success rate. Now, these are lame-free results. There was also another 17% in both the Bathe 2016 and Jansen 2012 that partially improved to the treatment but didn't become completely lame-free, or they would just exercise at a lower intensity than before treatment.
And it's quite interesting, how consistent sort of those different studies seem to be around, approximately that sort of 2/3 of the horses, a bit over, are responding and becoming lame-free. And something to bear in mind when we talk about the next couple of studies, because this was a pilot study that Leigh and I ran initially, again in Australia, in Melbourne. It was a single site prospective study. We had a total of 89 joints in flat racing thoroughbreds. Again, a majority were intercarpal joints. We had lameness at day 0, and then followed the horses through at 1, 4, 12 and out to 24 weeks. We also took radiographs on all of the horses, but most of the horses had none or very mild signs, so 54% had no radiographic signs. And that comes a bit back to what you were saying before, Greg, about the definition of what is osteoarthritis. And the more I've sort of studied this, I agree, and I think the new sort of definitions, looking at it, starts with synovitis. It starts very early on, and radiographs are very much end stage. And we know that you won't even see radiographic changes till you've got what sort of 40-odd% change in bone density. So they're pretty insensitive diagnostic tools, really very specific, obviously, but not that sensitive.
Yeah, when we do this in
small correlation too.
I was going to say, Jason, when we do this in small animal, we try to grade OA. I don't think we're grading OA in equine, anything like this, but we try to educate clinicians in small animal medicine that when we see things on diagnostic imaging, we're already at grade 3. Yeah. We're 50% into the disease process on a grade 1 to 5 before we get radiographic changes or any image changing.
Yeah, completely agree. And Leigh and I have sort of talked about this a little bit, and in our next study we do some different gradings looking at that. I mean, we're sort of working at the moment around mild, moderate, severe. How many do you go out to in the small animals? Out of interest?
5.
5. It's probably quite similar. If 0's nothing, so yeah, 0 to 4, 0 to 3 rather, 4 points. So interesting.
Yeah. I mean, I've moved away from even trying to use the term osteoarthritis, because I mean, technically arthritis is inflammation of a joint, and we know that a joint comprises, you know, subchondral bone, cartilage, synovium, and associated soft tissue structures, both within and surrounding the joint. So arthritis is arthritis. I think the osteo part, all that means, like you said, Greg, you've already hit stage 3 out of 5. At the moment you've got osteo in there and there's radiological changes, you're a long way down that river. So yeah, I think we just need I think arthritis is more of a key descriptor there. And again, radiological scoring, it's almost I don't think it's irrelevant at the time you take them, because you've got to make sure you do a thorough diagnostic process and see what's going on. But it's more of a benchmark for future examinations, more so than do you have arthritis, yes or no? Because realistically, if you're x-raying that joint, you should have enough clinical signs in front of you, the horse there, to know that you've already got arthritis.
Well, I think, as you know, right across the board medically, we're now looking at any long-term medication for a disease process, whether it be respiratory or joint disease. When a patient needs to be stabilized over any period of time, and I think one is now looking at a 3-month period, where if you've got to enter the joint or give what would regard as a long-term non-steroidal, that would be 3 months worth of non-steroidal assistance and medical assistance to that disease process. They are, regardless of whatever other diagnostic aid you use, a grade 1 of that disease process. So one could almost look at any intervention to that joint. I know this is quite controversial. That horse could be regarded as osteoarthritic or joint disease. They're forward. It doesn't go backwards. It only goes forward.
Yep, I'd agree. And I think it's consistent with what we see clinically, isn't it? It's just trying to put that into perspective with, I guess, some of the more technical definitions that we're trying to deal with. But ultimately, it all comes back to what we're trying to achieve, is managing these cases, because that's what we get measured on as veterinarians, which is always the challenge actually out there on the coalface. So I guess, yeah, quickly, the bar graph there, again, just showing the improvement into blue being the non-lame horses. So again, that response rate out to 4 weeks, where we start to see horses becoming non-lame, and then that increased out to 12 and sort of stabilised through to 24 weeks, quite consistent with Time Bar's earlier work. And again, sat around that 67% success rate. Interestingly, in that study, we had another group of 15% of the horses which were partial responders. So again, if you added the 67% to the 15%, come out with 82%. Again, consistent with Time Bar's work, that, you know, lame enough to, or sort of sound enough to stay and work, but not completely sound. So I think those partial responders is probably something we'll talk about later on, is it, Leigh? Quite an interesting group. So if you want to run through now, because I guess this is into the GCP study that you presented recently.
Yeah, so, you know, putting all that together, we discussed previously, the aim of this study was to compare the efficacy of this 2.5% polyacrylamide hydrogel in the management of naturally occurring intercarpal joint lameness in flat racing thoroughbreds in a controlled clinical setting. And we looked at 3 parameters here, clinical parameters, and that was lameness grade, joint diffusion, and reaction to flexion. So this wasn't a flexion test per se. This was just, like Jason touched on before, just picking the leg up and assessing it for, you know, range of motion, but then giving it as where possible, as consistent a crank on the joint to see that reaction to that. Because we certainly felt that that was more clinically relevant than standing there and holding a limb flexed for 45 seconds to a minute and watching the horse trot off after that. And the aim of this study was to obtain patient-orientated evidence as opposed to disease-orientated evidence. And we conducted this study in a double-blinded, randomized, prospective, positive controlled manner. So we had an independent assessing veterinarian, we had an independent treating veterinarian. The subjects were broken up into 3 groups and were randomly done so. It was conducted in a prospective manner, so we could control as many aspects as possible. And we put this product up against both triamcinolone acetonide and sodium hyaluronate. And so we looked at lameness grades. So that was 1 through 3 on the AEP scale. The horses then had intra-articular analgesia, and that was administration of 100 milligrams of pivocaine hydrochloride. And they had to block out within 10 minutes of administration of that. There were several exclusion criteria for this study. One was any arthritis that was secondary to a joint infection, arthroscopy that had been conducted in that joint within the preceding 12 weeks, and any intra-articular medication that was administered into the affected joint within 4 weeks. And animal ethics was approved, and informed owner or agent consent was given. And we also assessed quite a range of pre-admission variables to make sure there was no confounding in the 3 groups. And so this is the radiological score. Putting all that together, we discussed previously. The aim of this study was to compare the efficacy of this 2.5% polyacrylamide hydrogel in the management of naturally occurring intercarpal joint lameness in flat racing thoroughbreds in a controlled clinical setting. And we looked at 3 parameters here, clinical parameters, and that was lameness grade, joint diffusion, and reaction to flexion. So this wasn't a flexion test per se. This was just, like Jason touched on before, just picking the leg up and assessing it for range of motion, but then giving it as where possible as consistent a crank on the joint to see that reaction to that. Because we certainly felt that that was more clinically relevant than standing there and holding a limb flexed for 45 seconds to a minute and watching the horse trot off after that. And the aim of this study was to obtain patient-orientated evidence as opposed to disease-orientated evidence. And we conducted this study in a double-blinded, randomized, prospective, positive controlled manner. So we had an independent assessing veterinarian, we had an independent treating veterinarian. The subjects were broken up into 3 groups and were randomly done so. It was conducted in a prospective manner, so we could control as many aspects as possible. And we put this product up against both triamcinolone acetonide and sodium hyaluronate. And so we looked at lameness grades. So that was 1 through 3 on the AEP scale. The horses then had intra-articular analgesia, and that was administration of 100 milligrams of pivocaine hydrochloride. And they had to block out within 10 minutes of administration of that. There were several exclusion criteria for this study. One was any arthritis that was secondary to a joint infection, arthroscopy that had been conducted in that joint within the preceding 12 weeks, and any intra-articular medication that was administered into the affected joint within 4 weeks. And animal ethics was approved, and informed owner or agent consent was given. And we also assessed quite a range of pre-admission variables to make sure there was no confounding in the 3 groups. And so this is the radiological scoring that we kind of shimmied up. Certainly, we couldn't find anything consistently in the literature beforehand for intercarpal joints. And this was not so much the overall arthritic score, but just a radiological score. And if you look there, that we had it on an indexed scale. So what we felt was that sclerosis and lysis of carpal bones, there was mild sclerosis was deemed a physiological adaptation to exercise. But then, lysis was certainly something that was more, we deemed more pathological. And if you look at enthesiophytes, we felt that, mild enthesiopathies were also considered partial, physiological responses to exercise. But then, osteophytosis was certainly, the moment you got into that, you've got at least some degeneration going on in that joint. So we felt that should at least start it with any change had to at least be a grade of 1. So as we touched on earlier, so we had random allocations, and this was performed, the study was performed over 9 months, and the random allocation was done through a chart that was pre-generated. And so as the horses were enrolled, they were admitted into one of 3 groups. The blinded assessments and treatments, as we discussed, the controlled setting. So this was one training facility. So it's the same surfaces the horses have been trained on, farrier feed facilities, track riders, the whole lot. And the statistical analysis performed in a blinded manner. And the 3 groups that we had were 2 mils of the 2.5% polyacrylamide versus 12 milligrams of triamcinolone acetonide versus 20 milligrams of sodium hyaluronan, and that was injected intra-articularly on day 0, but then had 2 further intravenous treatments at days 7 and 14 of 40 milligrams. And all horses had 48 hours of rest, and then they resumed an unaltered training regime. And this training regime, none of these horses were sedentary. They were all up to at least galloping at this stage. And after the day 0 examination, we looked at them at 2, 4, and 6 weeks. And then we then followed through the 2.5% polyacrylamide group for 3 to 12 weeks as well. And we had 4 kind of outcomes for each variable there. And one was success, and that was deemed to be a complete resolution of the parameter in question. Nil was no change from day 0. Fail was a deterioration since day 0. And the withdrawn group, and these were those that were removed due to deterioration from the initial examination and could not complete the 6 weeks for ethical reasons. We also have to bear in mind that this was a commercial facility that had to take into consideration the economic impact of performing the study. So it was unfair, not only from an ethical point of view, but for also owners to have horses that were not able to race because they were sore. So we had that in there as an off-ramp.
Yeah.
So
we sort of ended up with that group because the trainer was also blinded to treatments and track riders, etc. So there were horses that were just hadn't responded, but they couldn't stay in the trial till 6 weeks. But we still felt they were treatment failures, so could be judged as such for the study. And as Leigh said, it took over 9 months to get the groups significant enough numbers in each of the groups to show statistical significance. And that again to us was a reflection on the strength of the blinding in a commercial racing facility, because as most vets would be aware, there's plenty of variables. There's horses coming and going. Suddenly they want to castrate them and turn them out, so would lose them to the study. Horses going lame for other reasons not related to treatment. So it did take a while to get the numbers through, but so it was very well overseen by an independent CRO organisation, so fully blinded in every way. And there's the results. So that's the pre-admission variables. Again, just showing the numbers in the different groups, their average ages. We divided them up posthumously into sprinter, miler, stayers, average lameness grades, effusion grades, reaction deflection, and essentially there was no confounding variables between the groups, so they're all equal at the start of the study.
yeah, so this is what we started with and what we ended up with at the end. So overall, we had 33 joints in the entire study. We had 12, 11, and 10 in the polyacrylamide, triamcinolone, and hyaluronic acid groups, respectively. And we did have a couple of horses removed from each of those groups, and they were for reasons unrelated to the study. We had a tendon, a tibial stress fracture. I think we had a colic, and I think we had 2 soreness, I think, as well. So they were removed from statistical analysis because they didn't get very far through. And if we go to the next slide here, so if we looked at, so lameness was our primary variable that we looked at, and this is the percentage of lame-free, which is the blue, versus the unsuccessful. So these are ones that were unaltered or deteriorated or were withdrawn as a result of deterioration throughout the 6 weeks. And this was assessed at the 6-week mark. So as you can see there, it's about 83% of the polyacrylamide group were laying free at 6 weeks, versus 27 and 40% of the two other control products.
And I think, again, what's interesting there is that the results in the triamcinolone and hyaluronic acid groups are consistent with the previous published studies on those products.
Yeah, if you look at a couple of the other studies, the triamcinolone in particular group they had 2 to 3 injections at either 7 or 14 day intervals for a period of up to 72 days, and they were still obtaining results into this. So, it highlights that we all like to think that, for everybody using the term, cortisone is great. It's a fantastic product, but none of the research really supports that. And certainly in clinical practice, we often tell people you'll get 6 weeks to 12 weeks out of a single injection, if you're lucky.
I think it's got its place, isn't it, in reducing acute synovitis and just trying to, again, part of the management protocol. But I guess we're all starting to recognise the deleterious effects as well. And
it's not a disease modifier. Cortisone it blocks prostaglandin. It stays within the soft tissues for 56 days. That's its pharmacological action. But as soon as that starts to dwindle, its half-life of its molecule starts to reduce overall its efficacy, then the disease comes back, because it is nothing but a treatment. And this is where we've got to look at our combination strategy, whether it be physical, whether it be pharmaceutical or biological, whatever you're trying to do has got to treat the disease, but also then modify the disease. And I think this is where we start to pull these products into 2 categories. The use of corticosteroids is nothing but a treatment. You're doing nothing to the disease process. It's just going to come back at a later stage.
Yeah, and I agree. And I think it's, like you say, recognising this more as an ongoing, complex interaction of different things happening at the joint at different times. So different interventions at different times are indicated. It's trying to use our knowledge and understanding of that to offer the best, isn't it, at those different times. And that's the challenge, I think, for vets that are out there, because there's no gold elixir that treats everything. I mean, the product come and gone. And
people also need to lower their expectations. I mean, it's this disease we're managing is managing. It's not treating. It's not a cellulitic leg that you can give antibiotics and some anti-inflammatories for a couple of days and you're right. You never, you shouldn't have to deal with it again. This is an ongoing management process, and I think for far too long, the industry has kind of thought that we jab it as needed, and that's managing the disease. Well, like you said, Greg, it's just reducing the symptoms of that disease until the product wears off, and then again it comes back to the same level, if not worse, afterwards. If we do nothing, if we don't change our management strategy. It's a multimodal attack on this disease that you need to need to use, and luckily, I think this product is allowing us a bit more freedom and giving some options to manage it.
Yeah, I think that's where owners need to be better informed. I mean, we look at other treatment options, and we've got to look at longevity, how long these products last, or the effect of using these products last, when we're giving that information to an owner, because their expectations are always way higher than the reality. Racehorse trainers are probably the worst. They want to be back out yesterday, not in 3 weeks or 4 weeks. But if we can start to give some indication as to the longevity of these treatments and how the management might link together with their expectations, then it's a team event, isn't it? You referred to that already. The owner, the trainers, everybody's got to get brought into this whole disease management as to how long these treatments go out for.
Yep, because we're all trying to get them there on competition day as comfortable as possible, and without, and understanding their welfare requirements as well, isn't it? And this is obviously the scrutiny that all equestrian disciplines, and I guess especially racing's coming under, just by the blanket sort of use of certain products. It's not sustainable for the world we live in.
Yeah. I agree.
The,
But yes, back to this one.
Yeah, the effusion. You go, Leigh.
Yeah, so this is interesting. So you can see here there's a very big difference between the three groups here. So this was complete resolution from day 0 at 6 weeks. So the interesting thing is that I suppose people are wondering, well, how come it was only 50%? Why was there not more? I feel that this doesn't take into account the very mild, subtle effusion present there. And I feel that knowing more now than what I did when we did conduct this study is that I think some of this effusion isn't necessarily joint fluid, because effusion realistically could be thickened skin, it can be thickened capsule, it can be thickened synovium, or it could be fluid. Now, we already know that this product incorporates into the synovium and thickens that out. And I think if we went back and did perform ultrasonography on these joints pre and post administration, I think you'll find different results to this that will be even higher than what we've got here. And that's certainly something I've started to do, is looking at the thickness of these, of the total thickness from skin right through to joint fluid, the predetermined points in the joints, and then monitoring those 3 till 6 weeks.
Would be trying to get it into some sort of objective measure, and I guess that is back to the viscosity samples. I mean, have you sort of thought any more about that, Greg, as to because obviously with your background and
you alluded to it earlier with the work that Mark Kuhner's doing in Germany, trying to find these degradation markers. I did a lot of work last year trying to find cross sensitivity, worked very hard, starting with subtle joints. We couldn't find a reliable test, these sort of ELISA tests looking at the degradation markers. They exist in human, they exist in different animal species, but we don't have a specific equine one. I went right up to a really osteoarthritic joint, trying to, go, higher and then try and find it go lower. Again, the sensitivity is not there. So we're a little way off trying to get a reliable test that we could have as a rollout. I know we can do it on low numbers. I know that Cambridge University, Matthew Allen's team has done really great work on finding those markers. But that's completely different to having something that we could have in clinical practice. And that's what I was working on, trying to have some sort of semi-automated ELISA test that we could have in, say, a referral practice, that they could use it as an objective outcome. Prognosticator was really where we were trying to head on that one. We still need to go back and do a lot more work on that, unfortunately.
Just as and if you look at this slide here, we've got the reaction to flexion that we discussed earlier, and this was conducted right through those time points, and this is results at the 6 week mark. And again, you can see there the clear difference in those results, and which is very encouraging, and also fits in with what's been seen previously with other research, but also the pilot work that we did before conducting this GCP study. So interestingly, as we said at the start, this product, the 2.5% polyacrylamide hydrogel, was superior in all 3 of those parameters statistically at 4 and 6 weeks. Interestingly, though, there was no difference between the 2 control products at any time point. And when we followed through the treatment group of the 2.5% polyacrylamide hydrogel, all that were lame-free at 6 weeks continued to be so through to 12 weeks. So that again just touched on the longevity of the product, and 12 weeks was as long as we could get out of conducting this study under GCP standards, which was quite arduous, as for those of you who ever conducted research would understand. So overall, we're really happy with the results, and it was very thoroughly done, and certainly supports the previous research done in more of the equestrian field.
Yeah, and this study's been written up now. It's just been submitted for journal publication, so we're waiting to hear back from the reviewers on that. But as Leigh said, I think this statistical significance there, p-values, confidence intervals, the 2.5% PAG superior and longer lasting than the other 2 sort of conventional treatments. So a real a useful product for, as we're saying, doing for what we want it to do, and helping us manage some of these horses. So, exciting stuff. So I think sort of we want to keep talking, I guess, some of our sort of clinical experience and clinical relevance. Some of the vets that'll be listening into this was, because those early published papers, I think, just sort of misled, not misled, but they were in chronic OA cases, and I think a lot of people have followed on with that and just felt that 2.5% PAG's only there in those cases, whereas the more we've used it, Leigh and myself and other veterinarians down here, we're just putting it in earlier and earlier in that disease process to help us manage these horses.
Yeah, and that from that it stems through that, we use 2 mils, and these were lame horses, and a lot of the other research had looked at 2 mils as well in the larger joints. So 1 mil in the distal and interphalangeal joints, and then 2 mils in the fetlocks, carpal and tarsocrural joints. And I think what certainly I've moved to, and a lot of other vets have as well, is doing the 1, 2, 3 process. So, a 1 mil injection is a horse that, as we were discussing earlier, it's maybe subtly off at the peak of its performance. There's a little bit of reaction deflection. There's a bit of effusion present, but there's no radiological signs, but it does block out in some form. But it, in terms of whether or not it's the reaction deflection disappears as it's been blocked, or the person riding it afterwards says, yep, no, this horse feels completely different afterwards. And they're the horses that we're using 1 mil on. And I certainly feel that the moment you have any radiological evidence of an arthritic process, going, they need 2 mils, and then 3 mil single dosage is reserved for those severe cases that have quite significant arthritic changes, severe both joint capsular fibrosis, thickening, and severe radiological changes. And that's certainly changed and morphed over the last few years since initial research was done.
Well, there's no doubt this is a pretty expensive treatment, isn't it? So I get, and some clients are, a little bit defensive, I guess, around the costs and doubling up. What are your thoughts, Leigh, on, because we sort of talked before about this group of partial responders. Is there any harm in sort of injecting the horse with 1 mil, seeing if you get a response, and then topping it up later on?
No, certainly. I mean, as a result of reading the other research thoroughly and talking to those authors and other vets that have used the product for longer than what I initially have, certainly if it's a dose dependent response, and I think if you can get away with a lower dose, then that's great. It's what we're all trying to achieve. We're trying to, and it shouldn't just be with it should be for all products. What's the lowest effective dose that we can administer of any product? Because that's what we're trying to do, because it minimises side effects, costs, etc. And so, yeah, certainly by all means, if you need to, or you feel that you want to, certainly put in 1 mil now and see what you get in 4 to 6 weeks. And if it's a partial responder, then put another one in. But it does have to respond. If there's been no change, then I wouldn't go back to putting another mil in. It has to at least improve.
Well, that comes back to your initial diagnostics, isn't it? And I don't think there'd be any joints that we would put it in that we haven't blocked out intra-articularly. If you get that good solid response to an intra-articular block, we're pretty comfortable that it's going to respond to this treatment. Whereas those that don't, you're obviously starting to look at other things like your subchondral bone changes and soft tissue injuries and the periarticular tissues. Would that be a fair comment?
Yep. Yeah, 100%. That's how I operate. Yeah. One interesting thing is that one of the conundrums you get faced with is that you get presented with a lame horse that's got to run in 2 weeks, or it's got a dressage finals in 12 days time. What do you do there? And I feel that in those cases, you do have to revert back to the conventional treatments that reduce symptoms and help modify the inflammation in there to allow the horse to achieve what the owner expects of it. But then I bring those horses back in 2 to 3 weeks after those medications and then administer this product in, because if it satisfies all the criteria of blocking out and from the clinical point of view, and then it responds to those initial anti-inflammatory medications, then you know that, yeah, you've got your diagnostic process right. Well, let's bring it back in and let's start managing this disease properly. Because all we've done is patch you up to get you through what you needed to. Now let's bring it back in and let's do it bang on.
I think it's also a point to make, Leigh, you touched on it there, is that clinicians need to understand what status you're about to put the joint into. We're about to invoke tissue growth. You know, if you're using a corticosteroid or something, you're not doing that. You're dealing with a symptom of a disease process, and it's pretty immediate how that blocks prostaglandin. By putting the polyacrylamide product in, you're invoking a tissue action. You're actually invoking tissue growth. And that's a lot of work for the joint to be going through. It's a lot of change to be going through. That's not something you want to be doing on top of hard exercise.
Yeah, yeah, absolutely. And I think it comes back again to you're talking about the more we can educate our clients, and especially around this product, it takes a lot more client education to get them to understand that. It's not a overnight instant fix. It's going to take 2 to 4 weeks to integrate and start making some changes. And I guess, again, it's the conundrum in clinical practice, isn't it? Like you said, Leigh, you always get that emergency call. It's just gone lame. It's a week or two out from a big race, a big competition, and you're supposed to be the hero vet. And I guess it ties in nicely to the narcissism of veterinarians' personalities. I'm not sure, but I think we all enjoy practice, and I know I certainly did, with our good clients that we had good relationships with, that you were there regularly and you were part of that team to manage those horses right through the competition season. So you got to know those horses really well, know their issues and their niggles, and be proactive in what you were doing for them. And I think this product really is a great tool in the veterinary kit for helping us achieve that. Because otherwise we're actually pretty limited in a lot of ways with obviously welfare, competition, drug withdrawal times, etc., to be the hero a week out from a competition.
Yeah, I mean, this, putting it simply, it's a disease modifying product that allows you to manage an arthritic affected joint to the best of its ability, which reduces lameness, which is pain, which has only got positive welfare implications. It reduces days lost in training. It is economically viable for the owner and the trainer of the horse, because they're there with horses performing at their peak, and we know horses don't perform at their peak unless they're feeling 100%.
And I think that's just on this slide there, talking about using other medications. And I guess, again, Greg, what you're talking about there is, sometimes diseases aren't, they are complex, and especially in racehorses, I think subchondral bone disease would still be the one that is the greatest challenge for us, because it confounds your diagnostics unless you're able to run scintigraphy on everything, or MRI. And obviously, again, treatment options with bisphosphonates. Are they commonly used in the UK still, or are people heading away from those?
They're not as commonly used as they were before, but I think every drug goes through that phase of use it for everything, and then it finally settles out at where you should use it. And I think that's where bisphosphonates have finally found their place, is people know when and where to use them. And again, it's not, the elixir for all lamenesses. So it is used together. And I think this whole thing about where you use it with other medication, there's another talk, we did a retrospective study of 361 horses and 804 joints. Without getting too much into it, if you want to watch that one, click into that one. But the finding that we had was that if you try to use this product with concurrent medication, i.e. at the same time using a corticosteroid or even a HA, we found the outcome to be absolutely no different.
Yeah.
You do not improve how this product works by mixing it with a corticosteroid. And we know that kind of happens sometimes in general practice. That doesn't mean what Leigh and Jason are referring to here is by stabilizing the joint first, treating an inflammatory condition first, and then moving away from a catabolic environment into that anabolic status that you're about to invoke.
Yeah, it depends so much, doesn't it, when you've got the horse, again, what stage of its competition are you in, and what are your treatment options to get it to where it's got to be. So yeah, I guess this slide again just showing that it doesn't directly affect subchondral bone disease. Again, we wonder in some of these partial responders, is it aiding joint function to just alleviate those shear forces on the subchondral bone plate? But that's just stuff we've talked around. There's no scientific basis to that. And yeah, just that comment there again around it requires a real different approach. Veterinarians really have to understand how this product's working, because it's very different to pharmacological action products. And consequently, you've got to manage those trainer and owner expectations. And I guess some of that on the next slide, Leigh talks about how you're starting to manage some of these horses and their rehab, and again, getting involved with that. But certainly our results are consistent with intercarpal joint disease. And as Leigh said, we have a saying in Australia and New Zealand, if it's not in the knee, just check the knee, because it's just such a common joint for us. But I know, having worked in the UK, yeah, it's, you know, you probably get different spreads. And I guess, yeah, this one was really just looking at that dose rate, which Leigh talked on before. And again, I know, having I've looked at your research on your case series out of the UK, which is incredibly interesting, just on some of those lower dose rates being used. And I mean, Leigh's talked a little bit about dose rates, Greg, and you've listened to that. What are your sort of thoughts? Obviously, knowing your own case series pretty well, what are you sort of currently recommending over there?
Well, I think the recommendation is pretty much as you've got on that slide, really. We don't stay away from that when we're advising people how to use the product. But what that retrospective data showed was really two things came out of that. Because the product comes in a 1 ml syringe, the sort of the economic side of things, it's a one, so I'm going to try the one. The other one is just a practicality side of things, of switching out a lock syringe and putting on another one. People have gone, well, that is an added complication I want to avoid, so I'm going to try 1 ml. So I think people have gone for the 1 ml purely out of those two factors, rather than thinking what might be the right dose rate for the pathology. Out of that data, you've seen that some of those cases do need a top up. So it goes back to what Leigh's comment is on a partial effect. And I think you've got two groups. You've got those groups that need it, you know, earlier as a partial effect, you know, within 2 to 3 weeks, you start to get an effect, but you don't get the whole effect. So then you need to top up between then and the 6-week point. But that data showed that even with just doing a 1 ml dose, you could get so far. And then the actual disease itself, or the use of the horse again, starts to deteriorate tissues to the point that it becomes symptomatic again. And that then becomes your top-up point.
Yeah, I'd agree. And I think, you know, perhaps in hindsight, isn't it, some of the, again, that early research that looked at end-stage OA, and they were using 2 mils and got those sort of results. You know, we've had... I've had a lot of vets contact me about it and say, yeah, we've tried everything else, and it's you know, it's an absolute terrible joint. And I've seen some of the X-rays which are catastrophic. And can we try 2.5% PAAG? And you're just like, well, yeah, you can, but it's not a good case anymore.
Yeah.
So, like you say, it makes sense to me. I think
Well,
and
if you look at that data. Of the 3 practices, one was a referral practice that had those refractory cases. It did show a degree of efficacy, a fairly good one. It was in the 60%. So, you know, treating refractory case, that one would look at results in the 60% would be a very good result, I think, in most situations. But we know the longevity is significantly reduced. You know, it's way within 12 months, but that's the whole nature of treating and managing a refractory case.
Yeah, so it comes back to what you were talking about too, isn't it, Leigh? I think if we can educate the public and ourselves as veterinarians to get in there and proactively manage this much earlier, and not waiting or taking quite seriously when an owner presents us a horse for lameness. It's a serious issue, and that we need to, perhaps just be a bit more proactive around it to give that horse the best chance for longevity, rather than sort of being more conservative early in that process, because like you say, you're actually already halfway through the process by the time they've got to a lameness stage.
Yeah, I think once you've, people, manage their clients differently, and different clients require different management. But I think once you start managing a joint for an arthritic process, you need to be looking at that joint or joints every month. Just a quick look, cursory look, trot the horse up. How's it feel? What are you doing with it? Flex it, check the fusion, and then and that gives you that guide of what's going on, and you can pick things up well before they become performance limiting.
Yeah, and I'll just add to this slide, I think for the people listening, the 2 mils and the Stifle. We don't deal with a lot of Stifle issues here. We're mostly thoroughbred racing practice. And that's really from Mark Kuhner's work in Germany, who I know is treating a lot of high-end sports horses. And I know that he's putting 2 mils into that medial femorotibial joint and getting some really good responses, even with mild low-grade meniscal tears, which again just comes back to that. To me, that is it, that tissue scaffolding effect that it's had, and actually allowing some that tissue to rebuild in there. I'd love to see it used in stifle cysts. We get a lot of cysts in young thoroughbreds here. I think the screw bridging is very effective for managing those in the medial femoral condyle. But I think also, could we speed up or improve the state of that healing with some anti-inflammatory benefits, and just stabilising the pathology and that potentially catabolic state, because some of those joints are pretty effused, aren't they, Leigh, when we see them clinically in these sort of yearlings?
Yeah, no, that would be interesting. That's one of the many questions that are yet to be answered on how far and wide reaching this product could be used. Definitely.
Yeah, when you start looking at some of the other soft tissue applications with pellets and things like that. Leigh, this slide, you talked to it because I'm just interested in your experiences of what you're recommending now for trainers and owners post-treatment.
Yeah, well, I suppose we all know that if you ask for 2 weeks of light exercise, they'll probably give you 2 days. So I always ask for a little bit more than I'm expecting to get. And like Greg touched on before, that's a biological incorporation of this product. And if you're out there, smashing this joint, by nature, exercise in itself is a catabolic process. There's actually no point in training unless you are inducing catabolism, because the body then reacts to that catabolic state by then trying to lay down new, better, more improved tissue, whether it be bone, tendon, ligament, muscle. So I do like to ask for 48 hours of complete rest. And then, certainly in all spheres, I do try to get the 2 weeks of light exercise if I can. And I just ask them for a lot of swimming, water treadmills if possible, even just light canter work, very light. Or if they're going to need to do something towards the end of those 2 weeks, then maybe a treadmill on a good incline if it's a front end, or if it's a back end that you've injected, well, then you can have it on the flat. But certainly, yeah, again, that's what I ask for. What we get in reality is far, far different to that. But it still seems to be working. But whether or not it works as quick or lasts as long, I'm not sure yet. But my gut feeling would be that it would take longer to work and probably wouldn't work for quite as long if you're thrashing those joints fairly soon after medicating them.
And in that regard, we've had a couple of horses sort of react to it. Both of those seem to be consistent with galloping exercise soon after treatment. Both of them responded to conservative treatment. It's interesting to know, isn't it, why we've had a couple of individuals, and it seems more related to those individuals, but certainly incredibly low numbers and no different to reactions that I've experienced with hyaluronic acids and things like that. So
far less than that.
Yeah, our experience, we've had we've had 4 reported, what one would regard as an ADR, an adverse drug reaction for this product. 3 horses, 1 dog, and on investigation, it was found that they were probably over-exercised. So, and you know, like you said there already, Jason, they were managed, you know, and you know, nothing, there's no long-term effect on those. And that retrospective study that we did, there were 2 reported reactions, not enough for it to be reported as an adverse reaction, but they were regarded as transient reactions. And in fact, both of those horses went on to achieve full work status.
No, I think that makes a lot of sense, and whether there's just something around the immune system. I think those of us that work with horses enough sort of always fail to understand just how poor their immune system is, or how weird it is at times. But yeah, look, it's a lot lower numbers, like you say, than other treatments, and certainly lower than other 2.5 or other PAAGs reportedly that have been used in other countries, which I guess again comes back to what Leigh was talking about previously around the stability and the porosity of this product to allow good full integration so it doesn't become encapsulated, which I think is critical. But it'd be interesting, wouldn't it, in those individuals, obviously once you've ruled out sepsis, which I assumed if they responded, none of them were, would obviously always be your number one concern with any intra-articular medication. But whether it's, their post-injection management, but I say that we've had other horses that have been galloped and exercised soon after injection and just haven't had a problem, but we certainly recommend that rest period, that's for sure.
I mean, they're the take-home messages on the right-hand side there. For those of you watching, it's 2 to 4 weeks realistically for it to work to its maximum effect. There does appear to be a dose-dependent effect of the product. Like all things, comes down to diagnosis. You do get a small amount of non-responders, so certainly don't do repeat dosage on those ones. But again, in that bottom take-home message, you can do repeat dosage on partial responders, and you can repeat the dose as and when needed. And as we said earlier on, it's 6 to 12 months, depending on a whole lot of things: severity of the joint, how the horse is managed, etc., etc. And the transient reactions, at this stage are reported to roughly around about the 1 in every 1,000 injections. If anything, it's probably a bit less than that. Probably closer to 1 in 1,500 or something.
Well, thank you, gents. So thank you, Jason. Thank you, Leigh, for that quite a long discussion on the product. I think we've covered all areas. If you've got any specific questions you'd like us to cover about the use of the product, or in particular pathology, joint pathology that you want us to go into more detail, your experiences, or even an area you think that you'd want to try but don't yet have the confidence in using a product like this, then feel free to come back to us. We've got a world of experience, which I'm sure we could help you achieve a better use or a better understanding of this product. There are other talks available around this product. There is the retrospective study, so I do urge you to go and have a look at that. And I think we'll be doing other uses of this product. I know that we've got a talk coming up shortly on this very new use of this product in urethral bulking in mares for urine pooling. There's some studies coming out of Kentucky in the States. So that's another very interesting area where this technology has been applied. So thank you very much for watching, and goodbye.